there, dear listener. My name is Nath Arwa. I am a clinical pharmacist by profession, and I would like to welcome you to part 2 of our infectious diseases MCQs. I welcome you to my channel, and I am the founder of Progressive Pharmacotherapy Consultants, your virtual Institute of Clinical Pharmacy, where patient safety, medication therapy management, and optimal clinical outcomes of pharmacotherapy are crucial and non-negotiable to us. Now, we seek to remain your premier source of tips for high-impact pharmacotherapy services. Welcome, dear listener. Now, in the first case, we'll talk about LAM, who is a 36-year-old female who presents to your A&E with severe back pain after falling during a scuffle. Now, from the social history, you establish that she is an active intravenous drug abuser or user who has been infusing or administering heroin for 13 years. Now, LAM is sexually active with one partner with whom she intermittently uses a condom during sexual intercourse. Now, you conduct an HIV test at the A&V, which turns positive, and she's not ready for HERT. So, you defer the initiation of the therapy, but arrange for an appointment. Now, a further outpatient follow-up is arranged and tests are done appropriately. And the following results are available during the next appointment meeting. Her CD4 is 370 cells per mm cubed. Her HIV viral load is 230,000 copies per ml, and her strain of HIV is not resistant to any of the commonly used drugs, but you establish that she is HLA B*5701 allele positive, and her CBC and Chem7 together the liver function tests appear normal. So, which of the following treatment options would suit LAM best? Would it be Rilpivirine together with tenofovir, alfenamide, and emtricitabine, which are co-formulated as Odefsey, taken at a rate of 1 tablet daily? Or would you opt to give no pharmacotherapy now and only wait to initiate it after the CD4 falls below 350? Or would you opt for Rilpivirine boosted with cobicistat, co-administered alongside emtricitabine and tenofovir alafenamide at a dose of 1 tablet once a day? Or would you opt for Dolutegravir, abacavir, and lamivudine, co-formulated as Triumec at a dose of 1 tablet once a day? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So personally, I would opt for option C. I would administer Rilpivirine, co-formulated cobicistat, emtricitabine, and tenofovir alfenamide at a dose of 1 tablet once daily. C is the correct answer. Now, option B is incorrect because ART should be offered to all patients regardless of their CD4 count. Now, the only situation where I would defer treatment is in patients who are unwilling to commit themselves to long-term long-term life treatment, because there would be a risk of default. Now, option A is incorrect, since NNRTIs like Rilpivirine don't form the backbone of first-line treatment. NNRTI-based regimens are no longer considered first-line, according to the DHHS guidelines. It is, however, considered an alternative regimen in certain clinical situations. However, these patients' baseline HIV RNA, the viral load, must be less than 100,000 copies per ml, and the CD4 should be above 200 for us to consider this as an option. Now, LAM didn't meet these criteria, especially for the viral load, and that makes this option unsuitable. Now, option D is incorrect. This particular regimen represents a recommended first-line regimen for treatment-naive patients only. But we know that LAM has a history of HLA-B*571 allele positivity, and that puts her at a risk of experiencing a Bacava-related hypersensitivity reaction. So that makes it very harmful. It is potentially fatal in nature. That reaction is a serious one. I would not opt for option D. Now, option C is correct and represents the recommended first-line treatment option for treatment-naive patients. And since LAM's renal function is normal, she should be good to go with Genvoya. So I would opt for option C. Now, LMM has been on the regimen Dolutegravir, cobicistat, emtricitabine and tenofovir alafenamide for the past 42 days, and she's been taking it consistently. She reports excellent adherence to a regimen with no side effects experienced. Now, labs are drawn, or were drawn, 14 days ago, and they show that her RNA, HIV RNA levels have fallen all the way to 50 copies per ml. Now, her CBC and liver function tests remain normal, although her serum creatinine has slightly increased from her initial value of 0.9 all the way to 1.15 milligrams per deciliter. Now, what would be the next best course of action for her now? Would you continue her current ART regimen because her renal function hasn't actually worsened? Would you switch her regimen to Dolutegravir, Rilpivirine, also known as Juluca, to avoid using NRTIs? Would you continue her regimen because the changes in renal function aren't attributable to her medication? Or would you change to Rilpivirine, cobicistat? Would you change the Rilpivirine, cobicistat to a boosted protease inhibitor regimen since her renal function has worsened? I'll give you 10 seconds to make a therapeutic decision. In my opinion, A is the correct option. Now, cobicistat can inhibit tubular secretion of creatinine without necessarily affecting the glomerular filtration rate. And these creatinine changes can be observed within 28 days of initiating therapy using a cobicistat containing regimen. Now, changes from baseline of less than 0.2 milligrams per deciliter just represent inhibition of secretion by cobicistat. They don't necessarily reflect worsened renal function. So that makes answer A correct in my opinion. Now, answer B is incorrect in my opinion. Now, LAM is not a candidate for therapy simplification with the option B at this point in her treatment, because she does not meet the threshold. She has not been virologically suppressed for at least 6 months. Now, option C is incorrect in my opinion. The changes in serum creatinine are actually attributable to the presence of cobicistat in her regimen. However, it doesn't reflect a change in LAM's glomerular filtration rate. And finally, answer D, in my opinion, is incorrect because the change in LAM's serum creatinine is attributable to the presence of cobicistat in her regimen, and her renal function hasn't actually worsened on treatment. There is no indication to change her treatment, in my opinion, at this stage. Now, LAM stabilized and decided to change scenes and volunteered to work in Soweto, South Africa for 6 months before returning to her hometown in the US, where, on falling sick, she presents to the clinic with fever, prolonged cough, and fatigue. Now, at this clinic, she was diagnosed with pulmonary tuberculosis after an X-ray was done, and her sputum turned positive on performing a nucleic acid amplification test. Now, LAM was initiated on rifabutin 300 milligrams daily, isoniazid 300 milligrams daily, pyrazinamide 1.5 grams daily, and ethambutol 1.2 grams daily, all taken once a day in a conformulated product. Now, in addition to that, she was also put on 50 milligrams of pyridoxine once a day to prevent peripheral neuropathy due to depletion of vitamin B6 caused by INH. Now, how, in your opinion, should LAM's antiretroviral therapy be modified based on her pulmonary TB therapy that you've initiated today? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So is the answer A, no changes are necessary, we should continue her current regimen as it is? Or is it B, change Dolutegravir 50 milligrams once a day plus emtricitabine and tenofovir alfenamide once a day? Or should we change to Dolutegravir 50 milligrams plus emtricitabine co-formulated with tenofovir disoproxil once a day? Or should we continue with our current regimen and adjust rifabutin to a lower dose of 150 milligrams orally once a day? I'll give you 10 seconds to make a decision. in my opinion, option C would be the best alternative. So we should change to Dolutegravir, emtricitabine, and tenofovir disoproxyl fumarate, 1 tablet once daily, and also avoid the others. Now, answer A is incorrect because concomitant administration of rifabutin or rifampicin with Rilpivirine boosted with cobicistat is contraindicated due to significant drug-drug interactions. Remember, there would be significant increases in serum levels of both rifabutin and rifampicin. Their areas under the curve would increase, and the two of them, being hepatic inducers, would lower or decrease serum concentrations of Rilpivirine through hepatic enzyme induction at the CYP level. This would lead to treatment failure. Now, answer B is incorrect because co-administering rifabutin and TAF is contraindicated. There is a possibility of a decrease in serum TAF concentrations due to induction of the P-glycoprotein transport system. TAF, as opposed to TDF, has major drug-drug interactions with rifabutin. Now, I would favor answer C because concomitant administration of rifabutin and Dolutegravir, though it results in a slight drug interaction, ends up in no changes in the Dolutegravir area under the curve. However, there have been noted reductions in Dolutegravir TAF concentrations of about 30%. However, this hasn't been found to be clinically significant, and the two drugs can therefore be safely co-administered. There are also no known drug-drug interactions between LAM's TB regimens and emtricitabine together with tenofovir disoproxyl fumarate. Finally, answer D is incorrect in my opinion. Although cobicistat can increase rifabutin serum concentrations due to other interactions that exist between TAF and the two drugs, we should not co-administer them together. So answer D is a bit inappropriate in my opinion. Now, in the next case, PBO is a 41-year-old male who inquires about a pill he learned about that can prevent HIV infection from friends that they hang out with. Now, after parting ways with his former sexual partner, unfortunately, PBO has resulted into indulging in frequent sexual encounters with other men with only intermittent condom use. A very unsafe practice indeed. Now, currently, he isn't on any other medication. Yeah, you establish this when doing medication reconciliation. Neither does he have any significant medical history. So my question to you is Mr. PBO a candidate for PrEP? So is the correct answer no? PrEP is only indicated for heterosexual serodiscordant couples? Or is it yes, he should take PrEP only before he has a sexual encounter? Or is it C, yes, he is an excellent candidate for PrEP and can start right away? Or is it finally D, yes, but he must have an HIV test done prior to initiation of PrEP. I'll give you 10 seconds to make a decision. So in my opinion, D is the correct answer. Now, option A is incorrect. PrEP is indicated for patients of very high risks of getting HIV infection from sex, from IV drug use, which also includes gay bisexual men who have sex with other men without using a condom, or who have been diagnosed with an STD in the past 6 months, or heterosexual men and women who don't regularly use condoms during sexual intercourse with their partners whose HIV status is unknown. Now, people who use IV drugs within the past 6 months also fall in this category. Now, answer B is incorrect in my opinion, because PrEP involves taking a combination of emtricitabine and tenofovir disoproxyl fumarate once daily on a daily basis to be maximally effective. So the decreased risk of contracting HIV is greater. Yeah? It's around 90% for sexual contact when it's taken on a daily basis. Now, there have been studies looking at PrEP taken just prior to sexual intercourse, but the prevention rates haven't been as impressive as a daily regimen. Now, in my opinion, answer C is incorrect because he must be tested and prove negative for HIV prior to initiation of PrEP, and having subsequent follow-up HIV tests every 3 months while on the same PrEP. And that leaves me with D as the best option. He is a good candidate of PrEP, but, and I'll underline the word but, he must have a baseline HIV test done prior to offering him PrEP. Now, in the next case, CVM is a 65-year-old African American male patient who presents to the hepatology clinic for a follow-up appointment after a diagnosis of hepatitis was made during an admission recently for the treatment of his diabetic foot infection. Now, he is a CKD patient. He also suffers from type 2 diabetes mellitus and is hypertensive. He lives in a metropolis and denies alcohol or drug use. Now, on close observation, you notice a tattoo of a rose flower on his abdomen. His home medications include 10 milligrams of amlodipine taken orally once a day, insulin glargine administered subcutaneously at a dose of 35 units at bedtime, and some of his labs includes a BUN of 30, serum creatinine of 1.9, AST of 80, ALT of 95, ALK4s of 165, TBD of 1.7, and his HCV RNA of 7 million units per ml, and he has a genotype of 1A, that's important, and the last two values show the degree of damage to his liver. Question to you is, which of the following is the most appropriate treatment regimen for CVM's hepatitis C virus infection? Is it Dolutegravir 300 milligrams administered with Preventosvir 120 milligrams taken orally for 8 weeks? it rilpivirine 90 milligrams alongside sofosbuvir 400 milligrams orally once a day for 8 weeks? Is it ombitavir taken alongside paritabravir boosted with ritonavir alongside dasabivir for 24 weeks? Or is it alternative D, sofosbuvir co-administered with semaprevir for 8 weeks? I'll give you 10 seconds to make a therapeutic decision. So in my opinion, A is the correct answer. So based on his genotype and lack of interacting medications, this would be a perfect and appropriate regimen for CVM. Now, answer B is incorrect in my opinion because based on the current guidelines, CVM's baseline HIV RNA and the rest exclude him from an 8-week option. There has been data indicating that the 8-week option is still efficacious in some patients of African American descent who have also HCV co-infected with HIV. However, the current guidelines still state categorically that CVM's race and baseline HIV RNA would exclude him from this option. Now, this option would have been appropriate for him had it been slightly prolonged for up to 12 weeks. Now, option C, in my opinion, is incorrect. The treatment duration for this particular regimen is 12 weeks, and it requires concomitant administration with Rilpivirine. Now, this particular regimen has also fallen into the yellow category according to the guidelines, and that makes it an alternative category due to the increased pill burden and the need for Rilpivirine compared to the other regimens. It would not favor the patient. And finally, option D would be an alternative regimen, not first line, for genotype 1A, but the treatment duration would need to be slightly extended to 12 weeks. So that makes it a wrong option. Now, CVM's kidney function deteriorates, and you decide on doing thrice weekly dialysis sessions, which are initiated prior to initiating the medication or the regime that you've decided to manage his HCV with. Now, will this decision affect the regimen of choice? So, would your answer be no? Glecaprevir, pibrentasvir can be used without renal dose adjustments? Would your answer be no? All HCV directly acting antiviral agents are hepatically metabolized, and none of them requires renal dose adjustments? Or would your answer be C? Yes, his therapy should be switched to elbasvir, grazoprevir for 12 weeks? Or would you opt for D, which says yes, his therapy should be switched to rilpivirine co-administered with sofosbuvir for 24 weeks? I'll give you 10 seconds to make a decision. In my opinion, the correct answer is A. These drugs can be used without renal dose adjustment. Now, this particular regimen was evaluated in the Expedition 4 study, which included patients with CKD who are also on hemodialysis dependence with no noted virologic failures. Now, answer B, in my opinion, is incorrect. While many directly acting antiviral agents for hepatitis C specifically are hepatically metabolized and they undergo minimal renal elimination, only a few of them have data supporting their use in the setting of hemodialysis. Now, in my opinion, answer C is incorrect because Rilpivirine for 12 weeks is an option for patients on dialysis, and was actually the first regimen to have a lot of good data in patients with renal impairment. However, the shortcoming is that we aren't given in this data or information his baseline NS5A resistance. That bit of information is very important. So we need it to establish if he's a candidate for this regimen or not. And it's also required, it requires a long-term treatment duration, slightly longer than the 8 weeks that is stated here. I also feel alternative D is incorrect. Now, safe and effective doses of sofosbuvir in patients on hemodialysis haven't been established at all. And there is no recommendation in guidelines to extend therapy using it for 24 weeks in this particular setting. So in my opinion, that would be a wrong answer. So in the next case, MOM is a white male who presents for a routine clinic appointment. He is HIV positive with a CD4 of 350. His RNA, HIV RNA, is less than 20 copies, undetectable, and he suffers from type 2 diabetes and experiences GERD. Now, he's a known intravenous drug abuser. He has alcohol dependence, and prior to meeting his girlfriend, JKK, he has a tattoo of a scorpion on his buttocks, which was done in a backstreet tattoo parlor in the slums of Soweto. Now, his home medications include lisinopril 20 milligrams taken orally once a day, pantoprazole for his GERD at a dose of 40 milligrams once a day, metformin a gram twice daily to manage his diabetes. He's also on Rilpivirine 1200 milligrams taken orally once a day, alongside emtricitabine co-formulated with tenofovir disoproxil fumarate, 1 tablet once a day. Now, despite his multiple risk factors, MOM hasn't been tested for hepatitis C virus. So my question to you is, how best would you assess MOM for the presence of chronic hepatitis C virus? I'll give you 10 seconds to make a choice from this list of 4. Is it positive HCV antibody? Could it be liver biopsy? Could it be transient elastography? Or is it a positive HCV antibody alongside detectable HCV RNA? So in my opinion, D is the correct answer. Now, liver biopsy is used to measure disease severity. It's not used to diagnose hepatitis C. Now, apart from that, answer B is incorrect because a positive HCV antibody alone could reflect acute or chronic hepatitis C infection. Now, given the number of patients in whom spontaneous resolution of the virus occurs, we wouldn't be able to conclude if he was chronically infected with the virus basing on the antibody alone. So that makes it a wrong choice. Now, answer D is correct. A positive HCV antibody and detectable HCV RNA indicate either acute or chronic hepatitis C. Now, transient elastography is used to measure liver stiffness. It would be a wrong option in this case. It helps in the staging of the disease, but is not used to diagnose hepatitis C infection. Now, after being diagnosed for chronic hepatitis C virus, MOM reports to the clinic for initiation of his hepatitis C virus infection treatment. Now, before this appointment, labs were done and the results are as listed there. Now, his current meds remain the same. So, which of the following regimens listed below would be the most appropriate for our patient MOM's hepatitis C virus infection? Would it be HCV therapy can't be initiated until his heart regimen is adjusted? Or would you opt for Dolutegravir 300 milligrams and 120 milligrams of pibrentasvir taken orally once a day for 8 weeks? Or would you opt for sofosbuvir 400 milligrams alongside rilpivirine 90 milligrams orally once a day for 8 weeks? Or would you opt for elbasvir 50 milligrams alongside grazoprevir 100 milligrams orally once a day for 12 weeks? I'll give you 10 seconds to make a decision. In my opinion, answer A is incorrect. Now, while ART regimens should always be evaluated for drug-drug interaction potential, MOM's regimen does not have interactions or interaction potential with the currently recommended hepatitis C regimens. So, in my opinion, there is no reason to defer or delay his treatment. Now, answer B, in my opinion, is appropriate for MOM. It is actually the first line regimen for genotype 6, as we've been told above. Now, option C appears incorrect to me. Data for sofosbuvir rilpivirine for genotype 6 is limited, and treatment is recommended for 12 weeks, not 8 weeks, as in this case. So you'd also want to provide some consideration to the potential drug-drug interactions that I foresee between this regimen and the pantoprazole that he takes for GERD. Now, answer D, in my opinion, is incorrect. it doesn't have activity against genotype 6 virus, which we are told about earlier in the text. So in the next case, patient NON, a 47-year-old male, presents to the clinic for routine HIV follow-up. Now, for the past 6 years, he has been virologically controlled on his current regimen. So his HIV was diagnosed in 2005, and so far we do not know of any resistant genotypes. He has chronic kidney disease, stage 3, and his creatinine clearance is about 30 ml per minute. And he experiences seasonal allergies and is a dwarf. Now he's an MSM who is a coal miner by profession and resides with 6 other male co-workers in a congested cottage, and is currently on Darunavir boosted with ritonavir, taken alongside bacavir and lamivudine. Now 30 days later, NON is admitted to hospital following a STEMI, and a PCI is done with the placement of a drug-eluting stent. Now after that, he's put on aspirin 81 milligrams alongside clopidogrel 75 milligrams, both taken once a day. Apart from that, he has metoprolol titrate 50 milligrams twice daily orally, and high intensity statin, atorvastatin, at a dose of 80 milligrams taken orally at night. Now, which approach would you adopt to minimize any ADRs and to avoid drug-drug interactions in the case of NON? Would it be substituting atorvastatin with pravastatin 80 milligrams taken orally once a day, or would you reduce the atorvastatin dose from 80 to 20 milligrams once a day at bedtime, or would you substitute clopidogrel with ticagrelor 90 milligrams twice daily, or would you double the clopidogrel dose? I'll give you 10 seconds to make a therapeutic decision. So in my opinion, answer A is incorrect. Pravastatin is associated with less drug-drug interactions with protease inhibitors, although there is a specific interaction between it and boosted Darunavir, which is mediated via the P-glycoprotein inhibition. So, pravastatin serum concentrations may be slightly increased by the boosted Darunavir. Now, additionally, because of NON's recent STEMI, he has an indication for high-intensity statin therapy, and we know that pravastatin has a low potency. It's a low-potency statin, and would not be very effective in lowering his LDL by 50% or more, as is required by guidelines. Now, in my opinion, alternative B is correct. Now, protease inhibitors and cobicistat, being strong CYP3A4 inhibitors, can interact majorly with atorvastatin. Therefore, atorvastatin doses in such cases should not exceed 20 milligrams. In fact, this 20 would be considered a high-intensity statin for such a patient, especially when used concomitantly with PIs. So if the dose was higher, there would be an increased risk of myopathy. So we can consider this 20 milligram dose as being functionally a high intensity statin. And in my opinion, answer C is incorrect. Ticagrelor is metabolized by the CYP3A4 enzyme system and should not be co-administered with boosted PIs due to the increased risk of bleeding. This drug may tend to accumulate because its metabolism will be inhibited. Now answer D also is incorrect in my opinion. Clopidogrel is converted to its active metabolite by CYP2C19, and both Darunavir and ritonavir do not inhibit CYP2C19. So dose adjustments are not warranted in this case. Now, during a follow-up appointment, NON's triglycerides are found to be grossly elevated. Now, despite adopting lifestyle changes which involve diet and exercise since his MI, the triglycerides continue to worsen over time. Now, as a clinician, what changes would you make to address this hypertriglyceridemia? Would you change his Darunavir ritonavir to Darunavir cobicistat, or would you change his Darunavir ritonavir to Dolutegravir, or would you change his Darunavir ritonavir to Atazanavir ritonavir, or would you change his Abacavir to tenofovir disoproxil fumarate? So I'll give you 10 seconds to make a therapeutic decision. So in my opinion, answer A is incorrect because cobicistat Darunavir regimens do not vary greatly from Darunavir ritonavir regimens in the development of hypertriglyceridemia. So while ritonavir itself is highly associated with hypertriglyceridemia, clinical studies haven't shown that this substitution of cobicistat for ritonavir would change his lipids significantly. Now, in my opinion, answer B is correct. Ritonavir boosted Darunavir is definitely the most likely medication causing this challenge with the lipids. And Dolutegravir doesn't appear clinically to have any effects on lipids and would therefore be a reasonable substitution in my opinion. Then answer C appears incorrect to me because Atazanavir is also implicated in increasing triglyceride levels, and making this switch isn't likely going to help this patient. Now answer D is also incorrect in my opinion because Abacavir doesn't contribute to hypertriglyceridemia. So swapping it with TDF wouldn't have an impact on his lipids. So during NON's follow-up visit, 4 months later, he complains of pill burden. He complains of being tired of taking so many pills and inquires if his regimen could be adjusted. So which of the following options below suits him best? Would you change his regimen to Dolutegravir monotherapy? B. Would you change his regimen to Dolutegravir Rilpivirine? C. Would you change his regimen to Darunavir, cobicistat, and lamivudine? Or would you change his regimen to Rilpivirine, emtricitabine, and tenofovir disoproxil fumarate? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So I personally feel option A is incorrect. There is currently insufficient data to recommend Dolutegravir monotherapy. Now, initial trials were promising, but the rise in virologic failure have subsequently discouraged this approach. Now, I strongly feel option B is correct. NON meets the criteria for regimen simplification to Dolutegravir Rilpivirine, since he has been virologically controlled for well over 6 months. Now, in my opinion, answer C looks incorrect. Now, technically, giving him these drugs would be regimen simplification because it would cut down his pill burden to just 2 pills. However, this represents a higher pill burden than his current regimen, and it also would likely cause challenges with the lipids, which he's running away from. Finally, D appears incorrect to me. Now, NON has CKD stage 3 with a creatinine clearance of 30. Now, due to his renal function, this regimen, despite being a nice one, once daily single tablet regimen, in my opinion, would not be ideal. It would affect his kidneys grossly. Now, as the clinical pharmacist at the HIV clinic, you are reviewing patients on the clinic schedule to identify potential candidates for regimen simplification as a way of enhancing adherence. Now, who amongst these patients listed below would be a candidate for simplification to Rilpivirine, Dolutegravir? Is it a 64-year-old male with HIV with no history of resistance and HBV who has been suppressed for 2 years on Dolutegravir, emtricitabine, and tenofovir disoproxil fumarate? Or is it B, a 36-year-old female newly diagnosed with HIV who is treatment naive with a baseline viral load of 88,000 copies and no resistance mutations identified on genotype? Or is it C, a 58-year-old female with HIV, hypertension, COPD, who has been suppressed on her original regimen of Atripla for 8 good years? Or is it a 49-year-old male with HIV, which has been suppressed on Dolutegravir, abacavir, and lamivudine for 1 year, who also has peptic ulcer disease for which he takes omeprazole 20 milligrams twice daily, half an hour before meals? So I'll give you 10 seconds to make a rational therapeutic decision. So in my opinion, C is the correct answer. Now, answer A, in my opinion, is incorrect because Dolutegravir, Rilpivirine don't have any anti-hepatitis B activity. And so, this patient who has been on the combination of emtricitabine, tenofovir, which has anti-hypertensive hepatitis B activity should remain on a regimen that contains antivirals with anti-hepatitis B activity to prevent disease reactivation. So I would not opt for this one. Now, answer B is also incorrect in my opinion, because Dolutegravir Rilpivirine doesn't or isn't indicated as a first-line treatment option in treatment-naive patients. It is labeled only for treatment simplification in patients who have already been virologically suppressed on other regimens for at least 6 months. Now, I strongly feel alternative C is correct. This is a perfect candidate for this kind of simplification. She has no history of resistance. She has been suppressed for 8 years on her current regimen since she was diagnosed, and that was well over 6 months, which is the cutoff. And given that her regimen is more updated and associated with more adverse effects, including CNS toxicity from their tripler and hyperlipidemia, she is a good candidate for this kind of switch to a potentially better tolerated combination of Dolutegravir, Rilpivirine. So I would consider this a correct option. And in my opinion, answer D is incorrect due to the drug-drug interaction potential between the twice-daily omeprazole and Rilpivirine. So this particular patient would not be a good candidate for this kind of switch. Now, B or O is a 32-year-old male patient who presents to the primary care provider requesting to start PrEP, which he heard about from a colleague in the office in his workplace, but he doesn't have much information about it. Now, BOO has been sexually active in a monogamous relationship with a HIV-positive transgender female for 3 years. The partner has been suppressed on HER for over a year. Now, BOO's last HIV test was done 4 months ago and it turned negative, and he denies taking any other medication, although on probing further, on doing a thorough medication reconciliation, he owns up that he takes concoctions of St. John's wort when he feels depressed. So, which of the statements below accurately reflects the use of PrEP in BOO? Is it emtricitabine co-formulated with tenofovir disoproxil fumarate is contraindicated with St. John's wort due to a drug-drug interaction? Or is it BOO's risk of contracting HIV from this partner is negligible to non-existent since she has been suppressed for over 6 months? Or is it BOO is an appropriate PrEP candidate who should be started on it at the clinic today? Or is it D, BOO is an appropriate PrEP candidate but needs a more recent HIV test and CHEM7 prior to initiating PrEP? So I'll give you 10 seconds to make a rational therapeutic decision. So, in my opinion, there is no drug-drug interaction between St. John's wort and the emtricitabine co-formulated with tenofovir disoproxyl fumarate. So that makes answer A incorrect. Now I strongly feel answer B is the correct option. Now, considering the U equals U campaign that is widely reported in literature, presuming that BOO stays in this monogamous relationship and that his partner stays suppressed, the risk of HIV transmission is negligible. So, the toxicities from the PrEP outweigh any benefits that BOO would derive from taking the PrEP. Now, answer C, in my opinion, is incorrect because based on the current situation, he's not a candidate unless the situation with his partner changes. The U equals U campaign indicates that he doesn't need it. Now, answer D appears incorrect to me because if BOO was a candidate for PrEP, he would need the most recent HIV tests and CHEM7. Based on the U equals U campaign, his risk of contracting HIV from this partner is negligible to non-existent. Now, if these patients have all been recently tested HIV negative, who among them is the best candidate for PrEP? Is it a 23-year-old man who has sex with other men with multiple sex partners and a poor adherence to medical care? Or is it B, a 43-year-old female who is an active IV drug abuser or user who is engaged in her city's needle exchange program and never shares her equipment with anyone? Or is it a 33-year-old female in a monogamous relationship with an HIV positive man who has been suppressed on HERD for a whole year? Or is it a 19-year-old man who has sex with other men in a monogamous relationship with a newly diagnosed HIV positive male partner? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So I would consider option A wrong because while his partners put him at a very high risk of HIV infection, his lack of adherence to medication or medical care is problematic in my opinion because routine laboratory testing and follow-up is very essential for patients to be good PrEP candidates. Now, option B also appears incorrect to me. Her drug use, her IV drug use puts her at a higher risk for transmission. However, she does not share equipment with anyone and uses clean needles through the needle exchange program. Now, her risks are arguably lower than some of the other options listed above. Therefore, PrEP is a bit less effective in IV drug users according to literature compared to those with sexual transmission. So I would consider this an incorrect choice. Now, answer C appears incorrect to me. The patient is in a monogamous relationship with a suppressed partner. Now, the odds of transmission here to me are negligible to non-existent. And in my opinion, answer D looks okay. It looks correct of all the three cases. So this is the best candidate for PrEP. Being in a relationship with a newly diagnosed partner. Now, in the next case, RBA, a 62-year-old female who suffers from COPD and morbid obesity and was tested positive for HIV in 1989, has had several regimens in the past and has been exposed to NRTIs, to NNRTIs and PIs, with an exception of Darunavir and Tiprenavir. Now, she is sensitive to all INSTIs, and she also reports to be CRR5/CXCR4 dual tropic. Now, for the past half year, she has been on Darunavir, cobicistat, atazanavir, Dolutegravir, and a combination of tenofovir alafenamide alongside emtricitabine. Now, her last HIV RNA was 22,500 copies per ml. Although she participates in the clinic's treatment adherence program and is known to be very compliant with her current regimen, she is not doing well. Her treatment appears to be failing. Which of the following strategies listed below would benefit RBA the most? Would it be substitution of atazanavir with tiprenavir? Would it be an addition of the new kid on the block, ebalizumab, to her current regimen? Or would you attempt giving Maraviroc 150 milligrams orally twice daily in addition to her current regimen? Or would you use 2 INSTIs and add Rilpivirine to her current regimen? I'll give you 10 seconds to make a rational therapeutic decision. I would like to start off by commenting that Maraviroc is indicated in patients who have CCR5 tropic virus. It blocks that co-receptor. Now, answer C therefore appears incorrect to me, since this patient has dual tropic virus. Now, Maraviroc would not add benefit to such a patient. In patients with CXCR4 co-receptors, it has no benefit. Now, answer A as well appears incorrect to me. Although her genotype indicates susceptibility to tiprenavir, this particular PI is associated with significant toxicity. Apart from that, it also requires co-administration with 200 milligrams of ritonavir, and it's contraindicated for concomitant administration with cobicistat and other PIs. It can also reduce serum Dolutegravir levels. Now, answer B, in my opinion, is correct. Ibalizumab was studied in a cohort of patients similar to RBA, and it increases her likelihood of achieving virologic suppression with good clinical outcomes. Now, answer D, in my opinion, is incorrect. There is no data currently that supports dual INSTI therapy. It has not been shown to have any additional benefit over a single INSTI. Now, in the next case, POK is a 58-year-old male who presents to his primary care provider after a recent diagnosis of chronic hepatitis C infection. He has a genotype of 1A and an HCV RNA of 5,800,000 copies. And he has compensated liver cirrhosis based on liver biopsy. Now his baseline NS5A testing wasn't done. He suffers from AFib, experiences migraine headaches which are exacerbated by the sound of a ticking clock. Now he spends most of his life in the ship, and he sails ashore once a month to attend to his clinics. Now, on probing, on doing a thorough medication reconciliation, he informs you that he's only on amiodarone for his AFib. So, which of the following regimens listed below best suits POK? Is it the Dipasphere, co-administered with sofosbuvir for 12 weeks? Is it Elbasphere, co-administered with Grazoprevir for 12 weeks? Is it Glecaprevir, co-administered with Pibrentasvir for 12 weeks? Or is it Valpetasvir, co-administered with sofosbuvir for 12 weeks? I'll give you 10 seconds to make a decision. So, in my opinion, answer B appears incorrect because we do not have the baseline NS5A testing, which is required for us to use this regimen. There is a potential drug-drug interaction between amiodarone and this regimen, so close monitoring would be warranted. Now, answers A and D appear incorrect to me because co-administration of sofosbuvir is contraindicated with amiodarone due to post-marketing case reports of symptomatic bradycardia, which in some cases resulted in admission. Therefore, that leaves me with answer C as the correct option. Now, this regimen is used for 12 weeks in patients with genotype 1A compensated cirrhosis. Now, those without cirrhosis can have successful treatment with a shorter duration of 8 weeks. Now, due to the PI component of this combination, there is still slight potential for CYP3A4 and P-glycoprotein mediated drug-drug interactions to occur with the amiodarone that the patient is on. So, I would recommend close monitoring. Yes. But unlike the options A and D, in this case, it's not a total contraindication for concomitant co-administration of this regimen with amiodarone. I would settle for option C. So, which of the following statements is true regarding POK in relation to relevant blood works that must be done? Is it A, he should be assessed for HBV co-infection prior to HCV therapy? Or is it B, testing for resistance associated substitutions should mandatorily be done regardless of the regimen to be administered? Or is it C, creatinine and hepatic function panel are recommended every 2 weeks during therapy? Or is it D, HCV RNA should be checked 28 days into therapy and therapy should be discontinued immediately if detectable. I'll give you 10 seconds to make a decision. So in my opinion, answer A is the correct option. Now, all patients should be assessed for HBV co-infection prior to initiating HCV therapy. Now, hepatitis C therapy has been associated with HBV reactivation post-marketing. Now, answer B, in my opinion, looks incorrect. Testing should only be performed for treatment-naive patients with genotype 1A infection that are being considered for Rilpivirine and Dolutegravir as the regimen of choice. Now, answer C also looks incorrect to me. Creatinine and hepatic function tests should be done at 4 weeks after therapy has been initiated, and from then on, only as clinically indicated. Now, answer D to me is incorrect. HCV RNA testing is recommended after 4 weeks of therapy and then 12 weeks after completion of therapy for complete sustained virological reaction. So with some older HCV regimens, the 4-week viral load was a good predictor of whether or not patients were going to respond well to therapy. However, the 4 weeks viral load isn't necessarily used for that purpose anymore, since it hasn't highly correlated with treatment outcomes with the newer agents that we have today. Now, some insurance companies in the US still require it for proof of adherence to therapy, and antiretroviral therapy shouldn't be interrupted or discontinued as such. If a hepatitis C RNA isn't available during treatment, and if it is detectable at 4 weeks, it actually just leads to a repeat test done at 6 weeks, in my opinion, to ensure the viral load is coming down. So I would not go for alternative D. Now, in the next question, PPJ, a 44-year-old Caucasian male was found to have hepatitis C during his recent admission, where he had a delusion of being able to fly like a butterfly. Now, today, he reports for his follow-up hepatology appointment. He is hypertensive and suffers from schizophrenia. He is homeless, but occasionally lives with his cousin JJR. Now, this fellow is known to spend approximately $120 on heroin on a daily basis. He is currently on omeprazole 40 milligrams once a day, according to the medication reconciliation you've done. And his labs are as listed there. I'll give you a few seconds to look at them. Which of the following statements regarding PPJ's HCV therapy is true? Is it A, HCV therapy is contraindicated for PPJ due to his ongoing IV drug abuse? Or is it B, HCV therapy isn't indicated for PPJ since he is unlikely to progress to cirrhosis in the next 10 years given his current metavir stage? Or is it C, PPJ's metavir score may preclude his insurance company from covering his HCV therapy? Or is it D, a decision on PPJ's therapy can't be made without a liver biopsy? For such, a fibroscan alone is inadequate for staging his disease. I'll give you 12 seconds to make a decision. In my opinion, answer A is incorrect. Now, as per the HCV treatment guidelines, recent or ongoing IV drug use isn't an absolute contraindication for HCV therapy. There is actually strong evidence from various settings in the US in which people who inject drugs have demonstrated good adherence to their treatment, and there have been low rates of reinfection, and additionally increasing numbers of IV drug uses in therapy can help reduce new numbers of HCV caused by decreasing the actual transmission. Now, answer B appears incorrect to me. Although Hep C is a slowly progressing chronic disease, PPJ's progression to cirrhosis can't be predicted, and treatment is indicated to prevent this kind of progression in all patients with HCV, except for those with short life expectancy, where we weigh the benefits of incurring heavy costs and the risks of death. Now, answer C looks correct to me. Many payers in the US, in Canada, restrict access to HCV therapy to specifically those with F2 disease or higher because of the cost implications. Now, answer D to me is incorrect. A fibroscan is an adequate test for staging PPJ's liver disease. So, my dear listener, I highly appreciate the sacrifice you made to sit, watch, and listen to me. If this video in any way benefited you, I would encourage you to subscribe to my YouTube channel, to view the video to completion, to like it, and to share it as broadly as possible with your colleagues. I wish you all the best as you offer effective and safe pharmacotherapy to your esteemed clients. Thank you very much for watching.